Well, hello. I am delighted to talk to you about ultrasound evaluation in the infertile female. My name is Dr. Elizabeth Pushak, and I am a reproductive endocrinology and infertility specialist and professor of OBGYN at Wayne State University. The disclosures I have are a number of clinical trials with industry. These are multi-center clinical trials, and I do not believe that these are going to interfere with this lecture since these trials do not involve infertility. The learning objectives for today include describing the role of ultrasound in the infertility evaluation, discussing the consequences of abnormalities in the ovary, uterus, and tubes regarding infertility, and describing treatment options to optimize the fertility outcomes. The focus is really going to be on the fertility evaluation and treatment options for the fertility evaluation. We are not going to be discussing treatment options once the evaluation is complete. The lecture outline for today is going to focus first on the definition of infertility, discussing the differential diagnoses for infertility, and then how do we assess our workup for determining which differential diagnosis for infertility exists. We will look at the ovarian reserve testing. We'll look at common ovarian abnormalities. We'll evaluate the uterus and tubes. We'll show images of common uterine abnormalities, some common tubal factors, and we'll briefly discuss the fertility treatments regarding some of these abnormalities as we go through these abnormalities, but again, not focusing truly on IVF or infertility treatments. And then we'll conclude. So when we think about infertility, its diagnosis, and when to do the evaluation, we need to realize that it's very prevalent in the United States. About 85% of U.S. couples conceive within 1 year, and this means there's at least 15% infertility in the country. 1 year of unprotected intercourse without resulting in a pregnancy is the definition. It is not 1 year of trying, it's just 1 year of exposure. We do start the evaluation earlier than 1 year of exposure for women that are older, over the age of 35, we'd say after 6 months. Over the age of 40, we'd like to get that evaluation happening immediately or very soon. And then, of course, if there's any history of a known cause, like somebody doesn't ovulate, then they should be evaluated sooner as opposed to later. And since infertility is really a couples disorder, we evaluate both partners concurrently. Traditional evaluation of the infertile couple focuses first on getting a history for both the female and the male. We do a physical exam, often focusing on the female's physical exam, and then if there's an abnormality in the male's laboratory assessment, like a semen analysis, then we'll look at doing the male's exam. We do preconceptional counseling, and then the evaluations for infertility include laboratory tests, a variety of different tests for ovarian reserve testing, ovulation detection, uterine cavity and tube evaluation, and then the semen analysis. When we think of the causes for infertility, about 40% of the time there's a male factor cause, about 40% of the time there's a female factor cause, and that leaves about 15 to 20% that's unexplained. That already adds up to 100%, but there can be more than one cause per couple. So about 20 to 25% of couples will have more than one problem. And this is why it's so important to evaluate both members of the couple concurrently, as opposed to identifying one factor and then treating it and finding out that, say if a woman's being treated for anovulation and we treat her for several months with a medication to make her ovulate, and find out later that the male doesn't make sperm, well, that would be a problem. So we try to do this evaluation, and we can do it within about a month's time, and I'll show you that in a minute. When we think about the differential diagnoses, these are ones that have been reported nationally. It's the only national database that we have which is through the CDC, and it is available to the public. And this just shows you that by the time couples are making it to do IVF, that the diagnoses may include tubal factor, uterine factor, ovulatory dysfunction, diminished ovarian reserve is one of more common abnormalities, endometriosis, male factor, again, similar in frequency as the diminished ovarian reserve, and then a number of other factors or multiple of factors. Our traditional evaluation has been an assessment of the male with a semen analysis. The assessment of the female is to look at each aspect of the organs that we already named. So for the ovaries, looking for ovulation with either an over-the-counter ovulation predictor kit, a basal body temperature chart, although we're not seeing those quite as often anymore. When patients bring either of these in, we're happy to review that. And then looking at a progesterone level that's over 3 or 4, depending on the assay system one's using, that can be an indicator that she's already ovulated. The traditional evaluation of the uterus has been with a hysterosalpingogram or an HSG, and then the cervix is typically evaluated by a physical examination. We tend to rule out other disorders like thyroid disease with a TSH, and we look for prolactin disorders. These can be subtly off and impact infertility. So it's very important to assess those as we go. So when you think about this traditional evaluation, we can do all of this within a month's time. So this is a typical basal body temperature chart where we can see a low temperature at the beginning of her cycle. The period is starting here up at the top the first few days, and her temperature is low, and then she'll test her temperature at first thing in the morning, and when she's getting close to ovulation, there's a low temperature, and then once it rises above about a half a degree to a degree and stays up, then she's already ovulated. And it's the progesterone that makes that temperature change, that core temperature change. So if we think about the initial evaluation of the traditional female infertility and evaluation, the baseline laboratory test may be done early in the cycle with an estrogen and FSH level. Typically, an HSG would be done early in the follicular phase before ovulation. The progesterone will be done after ovulation, maybe about a week later. And the semen analysis actually can be done anytime during the menstrual cycle. But you can see with this kind of evaluation, we can get it all done within a month's time. So it's not something that's drawn out over a long period of time. So when we think about this, where does ultrasound fit in? And we, along with the initial baseline laboratory tests, will do a baseline ultrasound to see if there are any abnormalities in the pelvis. And this is usually including an assessment of the ovaries and the uterus with both. I typically do 2D and 3D. Not everybody does 3D ultrasound, but it's a great way to pick up the uterine anomalies. And then instead of using an HSG, I've replaced the HSG with a saline infusion sonohystogram. We've been seeing a trend in this direction over the last few years, several years. And it's very effective means for looking at the uterus, and it fares well with looking at tubal patency with some of the newer technology. So this is how we see that ultrasound is playing a greater role in the infertility evaluation. The baseline ultrasound infertility is best done in the early follicular time. We typically will do it on cycle day. CD is cycle day 2 or 3. This tends to be the most informative time in the menstrual cycle because there shouldn't be any cysts in the ovary at that time. This should be a quiescent time period, so the ovary should be quiet, and the lining of the uterus should be fairly thin. So the heavy part of the period has already occurred, and the lining should be thin. We use a transvaginal probe because that'll be closest to the uterus, and then we take a systematic approach. Typically, we'll have the patient empty her bladder prior to starting the pelvic ultrasound, and then it's important to watch the screen as replacing the transvaginal transducer. This allows you to see if there's any fluid left in the bladder. Where you identify the bladder, you're actually going along the vagina. It's easy to see the cervix, and then that cervix helps point in the direction of where the uterus is going to be. So you can get an orientation to the uterus, and it makes it very easy to find. Once you see the uterus, we do a standard approach to looking at the uterus with looking in longitudinal fashion and go back and forth, and then we change to a transverse fashion. I'll typically do a 3D ultrasound at this point in time. We're measuring the standard measurements of the uterus, and then we're looking for the ovaries, note the location, size, and number of follicles. We're particularly interested in what's called the antral follicle count, which I'll go over in a few minutes, because that gives us a little bit of an indicator of the ovarian reserve. Again, 3D ultrasound can be very helpful, particularly to look at the uterus. In looking at certain uterine anomalies, it may be better to do the 3D in the luteal phase or with the saline infusion sonohystogram, but the baseline ultrasound is a great place to start when we don't know if there's a likelihood for an abnormality or not. So what can't ultrasound do? In this initial evaluation, we're typically not picking up things like minimal or mild endometriosis, although there are a number of papers now looking at how we can detect endometriosis with ultrasound. Certainly the endometriomas will have the cyst in the ovary, which can be very characteristic, and we can detect that with ultrasound. And if there's a lot of scar tissue where it's dense, we're going to be able to pick that up with an indirect measure with how the uterine and ovarian structures move. But the filmy adhesions we're not going to detect. We're not going to have a direct measure of pelvic adhesions by appearance on ultrasound. And then some of the subtle or smaller tubal abnormalities we may not detect on ultrasound, although hydrosalpingias would be something that we'd pick up easily with ultrasound. So let's start with our evaluation of the ovaries. Typically, the baseline ultrasound, we're going to be doing the ovarian measurements. We're going to be looking at what's called the ovarian reserve, and I'll talk about what that means. We'll look for polycystic appearing ovaries. We'll look for ovarian masses. And then the question mark here is, should there be a series of ultrasound for ovulation detection? Well, it's not cost effective to do multiple ultrasounds to see if somebody is ovulated or not. You certainly can detect a follicle and watch it grow and then watch it collapse, but it's just not a cost-effective way of doing that. So we focus on the other tests. For an ovarian reserve test, our goal here is to identify women who would be either at risk for a poor response or for a good response to medication, or even better yet, it would be great if we had an ovarian reserve that would tell me that this person's likely to be successful with pregnancy, or this one is not going to be likely with pregnancy. That would be an ideal goal for an ovarian reserve test. Unfortunately, most of our ovarian reserve tests predict the response to medications and not the pregnancy rate. The different tests that are available are a cycle day, 3 FSH, and estradiol levels. These we typically would want low. Depending on the laboratory, it'll often be a number that is less than 10 or 11. We will also have more recently focused a lot on the anti-Müllerian hormone, and this assay has improved dramatically over the years and can give a very good indicator regarding response. And the ultrasound measures that we're looking at for ovarian reserve would be the ovarian volume and the antral follicle counts. So the ovarian volume can best be done in the early part of the cycle, so we don't have any cysts in the ovary, and we'll do the standard measures of the ovary with the length, height, and width, and a lot of ultrasound machines now are calculating the volume for you already. If you don't have one that calculates the volume for you, you can use a modified ellipsoid formula to calculate the ovarian volume. The normal size varies by whether she's premenopausal, PCO, or postmenopausal. The PCO characteristic here is been consistent with the Rotterdam criteria of more than 10 centimeters cubed. Would be consistent with a PCO appearing ovary. the ovary is very sensitive to estrogen, so the premenopausal and postmenopausal ovaries tend to be smaller. The ovarian volume can also be done with a 3D approach where we're outlining the ovary in different planes and we get a volume this way. And we thought that might be more sensitive and accurate, and it seems to be sufficient to do it by either method. Ovarian volumes tend to be smaller when women have a poor ovarian reserve, where she's getting older, like over age 37, or she's gone through premature ovarian insufficiency. This says POF, but instead of failure, now we're using the word insufficiency, so premature ovarian insufficiency. Women, when they're on birth control pills, are not ovulating. Their ovaries are suppressed, and so the ovaries tend to be smaller on birth control pills. The ovarian volume tends to be larger in situations like polycystic ovaries. In women who have ovarian masses, their ovaries are going to have a larger volume, and if a woman's undergoing ovarian hyperstimulation syndrome, they're going to have a larger ovarian volume. Interesting, those patients that do have a larger ovarian volume due to a PCO appearing ovary are at increased risk for ovarian hyperstimulation syndrome. This is an example of an ovary that only has a couple of follicles, and this would be an example of a poor ovarian reserve. The antral follicle count on an ovary like this would be where we'd count each one of these little follicles that are less than 10 millimeters, and that would be how we'd count the antral follicle count. But this would be an example of an excellent ovarian reserve and a PCO appearing ovary. If we count these antral follicles, you'll see there are several of them. Our definition for antral follicle counts for ovarian polycystic appearing ovaries has recently changed just because the younger women were getting called PCO more often than not. But this has a characteristic PCO appearance with the pearl necklace sign of the ovaries, an increased stroma, and that's very characteristic for PCO appearing ovaries. If you think about polycystic ovary syndrome, there are a few different ways to classify PCO. The original was through the NIH that we used in the United States, and you need to meet both criteria of a clinical or biochemical hyperandrogenism and then a menstrual dysfunction and rule out everything else. That changed when we agreed to the Rotterdam criteria, which is a consensus of the European Society and the ESHRE and the American Society, ASRM, came together, and they included not only the clinical or biochemical evidence of hyperandrogenism, they also included the menstrual dysfunction plus the polycystic appearing ovaries, which was then 12 follicles that were 12 antral follicles that were between the sizes of 2 and 9. Again, this number has recently changed to be 25. The volume has stayed the same at more than 10 centimeters cubed. The Androgen Excess Society disagreed with the Rotterdam consensus statement because they felt like if you got only 2 out of these 3 clinical scenarios, you could get someone with PCO who had polycystic appearing ovaries and ovulation but never had the hyperandrogenism, and they could be called PCO under the Rotterdam criteria. And the Androgen Excess Society really felt that this was an androgen disorder, and so you needed to have the evidence of hyperandrogenism and then an assessment of ovarian dysfunction, whether it's anovulation or a PCO appearing ovaries. So it wasn't until these last two criteria that PCO appearing ovaries were adopted as one of the criteria for PCO syndrome. Another way that we can look at antral follicle count is using an automated 3D approach, and this one gives basically it's an inversion mode, giving a color code to each one of these antral follicles that you can see here, and they're actually measured, and in a separate table it'll have it color coded and tell you the size of each one. This particular modality initially was not great at looking at the antral follicle count, did better for looking at stimulated ovaries, and we're hoping to see this get better and better over time. So is 3D required for either volume or the automated AFC? Neither of them performed better than the 2D evaluation for volume and antral follicle count. So the 2D is certainly sufficient if you don't have 3D or are not comfortable with the 3D. I use the 2D certainly for the ovarian assessment. Here's some of the data that shows you the ovarian reserve tests and how they fared. And this is for an ideal test, you'd want to see kind of a right angle approach here with sensitivity on one side and 1 Maya specificity on the bottom. So that would be the best test. The worst test is going to be the one that has the diagonal along the side here. So if we look at the different types of tests, the total antral follicle count has been one of our best predictors. The AMH has been also an excellent predictor, and then our other tests have fallen kind of in the middle here. So yes, that's that arrow shows you what you want for the best test. So AFC and ovarian volume, if we look on the left panel here, you can see that the black spots are the AFC, and they tend to follow this right angle a little bit more than the ovarian volume, which tends to be a little bit lower, and that's for predicting a poor response. When we look at prediction of not getting pregnant, neither test did very well. So the antral follicle count is certainly a better predictor of ovarian response, and neither are great for detecting pregnant, whether someone will get pregnant or not. Okay, so not so great there. The meaning of ovarian reserve. So here again we want to look at the ovarian volume. We have a low ovarian volume, we have a low antral follicle count, we have a low AMH. This person has a poor ovarian reserve. It might be due to age or premature ovarian insufficiency or birth control pills or some other reason why they have a very low approach would be some other hypoestrogenic effects. A high ovarian volume or a high AFC, so a high count or a high AMH, is suggestive that there might be an underlying PCO or an increase in response to medications or a higher risk for ovarian hyperstimulation syndrome. So we're going to probably treat her with less medication, and we will be much more wary after we do an ovulation induction to look for ovarian hyperstimulation. If we see a high ovarian volume and a low antral follicle count, well, then there may be more likelihood that there's ovarian cysts or masses that are giving us a false expectation regarding the ovarian reserve. When there is an ovarian mass in the ovary, it's going to artificially give you a lower antral follicle count. So we typically do not want to count the antral follicles when we see a cyst or a mass present in the ovary. So the ovarian reserve is used clinically very often. We use it to counsel our patients, to let them know that they'll be a good responder to medications, and we'll use maybe an average dosing, or they may be a hyper responder, maybe we'll use less medication, or they're going to be a poor responder, in which case we're going to need to use more medication and it'll be more expensive to them. So it really helps us with choosing the protocol and letting our patients know the expectation. And I think it's very important to let our patients who are very anxious to know what to expect when we're stimulating them with some of these fertility drugs. So we're relying on the antral follicle count and the AMH for a number of these counseling regarding protocols. I still look at the FSH too. So the baseline ultrasound may also detect ovarian masses. Most of the masses that we're going to see in a reproductive age woman are going to be physiologic, like a follicular cyst or corpus luteum. There may be a simple cyst that resolves the next month, so these could be a functional cyst of one form or another. Pathologic cysts that we tend to find in the reproductive age women tend to be things like endometriomas, some teratomas, and it's certainly a lot less likely to see any borderline tumors or malignancies. However, if we see something we're worried about, we certainly would want to do a further evaluation of the pathologic abnormality prior to doing any fertility treatments. And to further assess this, it may be repeating the ultrasound in a month, or if there's something we're particularly worried about, it may be going to laparoscopy or doing some testing and sending her off to GYN oncology. So I'm going to show you some common masses that we see in the ovary. And usually when they're seeing a cyst or a mass in the ovary, I always want to use Doppler to evaluate this mass. So here we see a simple cyst here. The blood vessels seem to be over here. I'm not seeing too much going around here. This is a simple cyst, and we'll often repeat this in a month to see if it's gone away right at the beginning of her cycle to see. Again, that's when the ovary should be the most quiet. Here's we see another ovary that's being measured here, and there's another cyst with some low-level echoes. You can see a little shadowing that's a little hyper intense behind here, and that's very common for an endometrioma. When we're seeing characteristic findings of an endometrioma with smooth borders, these low-level echoes, then our accuracy in diagnosis by ultrasound is about 80%, 90%. If it's atypical, then that is not true, but a typical abnormality, a typical appearing endometrioma is about 90% accurate. On this one, we're seeing two cystic structures. We're having the power Doppler here, and we can see vascular flow going around. This is a hemorrhagic corpus luteum cyst. Again, after ovulation, there's an increase in blood vessels that go around those follicles, and so it lights up very nicely for us. Again, these will resolve in a month's time. This one may look a little bit more scary when you're seeing a cyst like this that has both a liquid portion and a solid portion. We see these kind of a little unusual spicules here. This is one where if you just jiggle it, you may get a what we call a jello sign, and you'll see the solid part kind of wiggle like jello. Just by moving your vaginal probe up and down. This image was courtesy of Beryl Benassarath, and it is consistent with a hemorrhagic corpus luteum. Again, these are going to resolve. This is a clot. That's what the solid part is. If you run color over it, you're not going to see any color flow Doppler going into this area. It does jiggle, and it's just liquefaction of the clot, and it will be resorbed. This one is a stimulated ovary, and we see a hyperechoic area with some shadowing, and this is very consistent with a dermoid. And we do see a number of dermoids in reproductive age women. Of course, they don't tend to go away. This next ovary has vascularity going around it, and this is another hemorrhagic corpus luteum cyst. So they can have a variety of different appearances, and some of them look a little bit more worrisome than others. Again, they tend to resolve within the next, by the next cycle. One of the references that you might find very useful is an article entitled Management of Asymptomatic Ovarian and Other Adnexal Cysts Imaged at Ultrasound. This is a consensus statement of a number of experts in a variety of fields that are related to ultrasound regarding ovarian masses. And in this particular article, there are these templates that you can just pull out, and the whole idea was to give you a reference that you could actually use clinically that describes in words the different cysts that you can see that would have benign characteristics, an image of what that typically would look like, and then the recommendations regarding follow-up and any other comments. So we broke these into categories of cysts with benign characteristics, cysts with indeterminate but probably benign characteristics, and then cysts that we were more worried about, where we'd want to have a workup done right away and probably a surgical evaluation. So I hope you can find this article useful. The uterus, we do a baseline ultrasound on cycle day 2 or 3 to evaluate the uterus, and then later a saline infusion sonohystogram is a great way to look at the uterine cavity, and then we'll also talk about tubal patency shortly. So this is a 35-year-old giving you a clinical scenario of a G3P0030, so she's had 3 losses. She's presenting also with infertility. Her baseline ultrasound is here. We can see a nice anteverted uterus with a fairly thin stripe here, and that would be a fairly normal 2D ultrasound by what we're seeing in this slide here. One reason I like 3D ultrasounds is because it can give you more information, and this same patient had a 3D ultrasound, and you can see here that it has a characteristic look of the uterus going off in one direction. This is a rendered view with the endometrium angled like this. It's very consistent with what we call a unicornuate uterus. We would not have detected this by 2D ultrasound at all. It takes 3D ultrasound to pick up this kind of abnormality. So how do we do 3D ultrasound? What's involved? When we do 3D ultrasound with a transvaginal probe, it's basically taking, it's an imaging technique that's capturing multiple planes at the same time, and we call this volume that's being captured measured in voxels, and it's done with a single automated sweep. So basically you put a box around the organ that you're interested in and then activate it, and you'll get a sweep of that particular volume in 3 planes, longitudinal, transverse, and then what you don't see in 2D but you do get on 3D is the coronal view. And then you can look at the results of this automatic acquisition of the volume in either a multiplanar view or a rendering view, and it can improve the diagnostic accuracy of some of these uterine malformations. So here's a multiplanar view of the uterus. I'm going to describe the Z technique that was originally published by Alfred Abdelhamid. And basically when you do your initial capture of the uterus, you're going to get something that looks like this, 3 different planes, A, B, and C typically. And there's a little dot that comes up. And typically the dot is the same reference point wherever you are in A, B, or C. It's the same location. And so we utilize this technique to first take the dot, and we will move it to kind of the midline of where we want to be. And then we will activate each one of these planes so that it'll be in the horizontal view. So move the reference dot first to the middle of the endometrium, and that's that reference dot. And then we're going to focus on getting a coronal plane. So once we took that reference marker, moved it to the endometrium in the mid-sagittal plane, use the Z knob. So there's a X, Y, and Z knob, and the Z knob is the one that's going to rotate along the long axis in that panel A, and they're going to put it in a horizontal position. So we'll activate the plane B, which should have the uterus in the transverse plane, and then we're going to use move that same reference dot to the middle of the endometrium in plane B, and we will use the Z knob again to rotate it to the horizontal position. Once we have done that, then we look at the coronal plane, which is the C plane, and typically you'll see the coronal view right then, and you just are going to be using the Z knob to rotate the image into a vertical position. You may need to use a few minor adjustments to do this, but you'll get a nice mid-coronal plane. There's another knob that's called the slice knob, and it's important to rotate this so you're actually going through the whole coronal plane and you're not missing anything. And I strongly recommend that also. So here we have a keyboard, that's going to show you where these knobs are, and each ultrasound machine has a different keyboard, unfortunately, but they all have these X, Y, and Z knobs. And on this particular one, they're located here, X, Y, and Z, and then you have the slice plane, X, Y, and Z. And again, we'll turn the Z knob so it's in the horizontal. We activate the B plane and move the dot to the middle of the endometrium and turn the Z knob, and you'll get a nice horizontal plane like this. And then you'll rotate so it's in the horizontal position, and then we're going to activate the C panel and rotate with the Z. So you can see this happens to be a normal uterus as we've done this. You can see the top of the uterus and the inside of the uterus as this happens to be done during a luteal phase, which you notice because it's a thickened endometrium here. And it's a great way to look at the myometrium of the uterus and the endometrium of the uterus. So you can see the outside portion and the inside portion to see that that's normal. Oftentimes I'll get a transverse view like this where someone who doesn't do a lot of ultrasound will tell me, oh look, we have a bicornuate uterus because we have this nice transverse uterus with an endometrium here and an endometrium here, and there's obviously a bicornuate here. Well, how do we know that? How do we know that that's truly a bicornuate and not a septum or an arcuate? Or maybe there's something else in here that is causing it to be an artifact that gives you a funny view. So you can't determine this on 2D ultrasound. Here's another transverse 2D ultrasound, and again, you can't determine it. You see two endometriums, but you don't know what's causing this dropout here. The Mullerian duct anomalies are where the uterus, which is made up of two Mullerian ducts, has not developed normally. So if we look at the categories that were initially described in the, at the time it was called AFS, American Fertility Society, now it's ASRM, but this was back in 1988 when it was first published, and there are other individuals that have described Mullerian duct abnormalities a little bit differently, but I think this one is pretty useful for us. So if you think at table category 1, this is where the uterus is hypoplastic or isn't existing. So no uterus is a good way to think about that. Type 2 is the unicornuate uterus, where one tube developed and either the other tube didn't develop at all, as in D here, or it partially developed here with no cavity or with a cavity but not communicating, or with a cavity and communicating. And we already looked at one unicornuate uterus. There's also uterine didelphys. This is where both tubes developed, but there was no fusion. And bicornuate, you can see the bottom is fused, but the top was incomplete fusion. And then septate or subseptate uterus, where you have the fusion, so the tubes have come together, but the inside portion has not resorbed. And what we're talking about for this dropout, it could be either 3, 4, or 5, or even 6 could be picked up as one of the categories when we're seeing a transverse uterus with two endometriums. It could fall into any of those categories. So we really need to have a better way to look at the top of the uterus to see, is it an indentation here, so that it's a bicornuate, or is it smooth on the top like a septum, or is a decrease on the septum on the inside so little that we call it an arcuate. DES has really not been used in the last several years, so we're not seeing the T-shaped uteruses often. I'm going to show you some abnormalities here. This is kind of a drawing of some of these abnormalities, and here's the ultrasound images that have been enhanced by using 3D ultrasound. And you can see nicely when we put the line above between the two cornua, whether we have a dip in here, so we see the heart shape here on the outside and heart shape on the inside. That's going to be consistent with our bicornuate uterus. The next one we have is also bicornuate, but it's not, hasn't dipped quite as low as the other. And then the next one is a subseptate uterus, so it's smooth at the top, and then the indentation is more than 1 centimeter. The accuracy of imaging, when we take 3D ultrasound, compare it to laparoscopy and hysteroscopy or MRI, have all similar outcomes of about 92 to 100% for 3D, 96 to 100%. Those are pretty equivalent. Transvaginal ultrasound alone 2D is not as good at picking that up, and then HSG is also going to have its problems because a hysterosalpingogram is just where we're putting dye into the uterine cavity, and we can watch where the dye goes under fluoroscopy and do some x-ray films, but we just see where the dye goes. We don't see the uterus, and we don't see the ovaries. We just see where the dye goes. So it's the least effective way of picking up uterine anomalies by imaging. So 3D ultrasound and GYN is critical for detecting both the congenital uterine anomalies and also for IUD placement. Obviously, for the infertility evaluation, we're really hoping she doesn't have an IUD in place, but 3D ultrasound is very helpful for making sure that's in good position. The uterine cavity evaluation is typically evaluated by a hysterosalpingogram or a saline sonohystogram. Both of these tests are done between cycle days 6 to 12. The idea here is that we want to evaluate the uterine cavity when the endometrial lining is the thinnest. So she hasn't ovulated yet, she hasn't gotten the endometrium too thick. So sometimes when you get into 11 or 12, that's a little bit on the thicker side and may not be as informative. So we like the patient to let us know when our period's over and try and do the procedure as close to when the period's over as possible. Do we pre-treat these patients? I do offer non-steroidal and inflammatory medications like ibuprofen, an ibuprofen type product. Antibiotic prophylaxis is typically not needed. However, if somebody has a history of tubal disease like PID, then I will often pre-treat them with an antibiotic such as doxycycline, which is pretty cheap. So in HSG, the advantage is that it is an assessment of the uterine cavity, and it does an excellent job at that. It can tell you if the tubes are patent, if we see the dye going out the tubes, and we have a film, so we have something for posterity. The disadvantages is that there's ionizing radiation to the patient and the doctor, because the doctor is likely to be doing more of these than the patient is. It's using an iodinated contrast, which can be irritating to some patients. It has to be done in a radiology suite where we have the C-arm to do the fluoroscopy. We're only getting an evaluation of the interior contour of the uterus, not the outside, and there's pain associated with this procedure. The saline infusion sonohystogram, in contrast, is done in the office, not the radiology suite, so it's in the gynecologic office. It takes a few minutes to be done. You see the view of the uterus, the ovaries, not just the cavity. There's no radiation. There's no iodinated contrast being used. You can just use the warm saline or sterile water. It seems to be less painful. It's not, patients seem to be less anxious because they're in an office surrounding that they're familiar with people that they're familiar with being taken care of in the same office that they go for their usual gynecologic care or infertility care. It is okay to do this procedure if there's some bleeding. Usually lighter bleeding is better than heavier bleeding. When there is bleeding and there's a clot in the uterine cavity, sometimes that can be an artifact that can be misinterpreted. So you just need to know if she's having some bleeding and then keep that in mind. Often I'm doing this procedure without a tenaculum. I'd say 99% of the time I'm doing this procedure without a tenaculum, so it's less painful because of that as well. The disadvantages, some people argue that you can't see tubal patency as well. And in our practice, over 80% of the time we can tell if one or both tubes are open. Some others will argue that the disadvantage is the tubal anatomy. Well, certainly if there's a hydrosalpinx, that's a big factor for us in infertility. We want to be talking about removing that tube, or if it's a smaller hydrosalpinx, we might fix that tube. But we can't see the tubal anatomy, whether or not the folds are normal or not with this kind of approach. I would argue that that's less important for our fertility evaluation. So prior to doing a saline infusion sonohystogram, typically we'll have that baseline ultrasound. We're going to be looking for any abnormalities before doing the procedure, like congenital uterine anomalies, fibroids, adenomyosis, adnexal masses, evaluation of the endometrium. We'll evaluate for any cornual tenderness. So we'll actually use the ultrasound and probe near where the tubes enter the uterus to see if there's any tenderness. If there's pelvic tenderness, then we'll stop the procedure and start an antibiotic and have her come back when she's not tender. And then we'll also be screening for uterine positioning as well. The setup for SIS is very similar to what we see for an HSG. We'll need a speculum, we'll need a container for something that we're going to use to disinfect the cervix, we'll need a mechanism for doing that. And usually I'll use large swaths, but you could use 4x4s, and then you'll need a syringe to draw up your diluent that you're going to use. And I'll typically use sodium chloride as our distension media. You can use an iodine prep for the prepping the cervix, or a non-iodine based prep would be fine as well. These are the different types of catheters. There's many different catheters. I'm trying to just show the example of some that have a balloon, and for the balloon catheters, I try and put these just in the cervix, not in the uterus. That tends to be best tolerated. There's a little knob there that you can see, and I put that right at the external os, or just slightly inside the external os, so it stays in the cervix. This one has an acorn, and this is meant to go up against the external cervix so that it blocks the efflux of fluid. This can be moved up, so you can, the black mark is kind of an average uterine depth, so you may want to move this acorn up to that spot, or if she has a larger uterus, they'll have to move it back. If she has a smaller uterus, they'll need to move it up forward. And you can also bend this catheter, and it has some memory, so you can angle it whichever way the cervical canal goes, and you can place it, and you just hold this against the cervix. I usually use a ring forceps to help place this, and then remove that when I'm just injecting the fluid. And then this one just happens to be an IUI catheter, but it's just to be an example that if you wanted to just get an assessment with just a little bit of fluid, you could do that even without a balloon or an acorn. And this technique was originally described with, I think it was a pediatric feeding tube. So there's been a number of different types of catheters that have been used for this procedure. I like to have something that blocks the efflux if I'm interested in looking at the tubes. So there's that balloon, that's the acorn. So choosing the catheter may be based on whether a person's been pregnant and delivered or not. So a nulliparous, you could use either one. For a multiparous, the balloon's often going to fall out of the cervix, so you either are going to have to place it in the uterine cavity, where it's going to be a little bit more painful. Just remember that if you place it in the uterine cavity for the evaluation, at the end of the procedure, you need to deflate the balloon so you can see the lower uterine segment well. You can use the acorn in either the nulliparous or the multiparous patient. So preference of the provider is usually what makes the decision on which catheter to use. And as mentioned, if you're going to use the balloon, it's best in the cervix, where it's least painful. The acorn, the advantage of the acorn catheter, does seem to be a little bit more rigid catheter, but it will need some guidance. So if we look at catheters and their placement, here's that acorn being placed at, so that it's just at the external os, and it's kind of acting like a stopper here. And just remember, you can move that acorn up and down so it makes the right positioning for patients. Typically that internal catheter will go up to the top here, but you can pull it back. And this is a balloon catheter. It can be in the canal or the uterine cavity. This one happens to be in the cavity. I tend to like it down a little bit further because I think it's better tolerated there. There was a nice study that looked at pain and catheter placement, and they found that the pain was less if it was intracervical as opposed to intrauterine for that balloon. And the time was the same for the duration of each approach, and the volume of descending media tended to be less if you had the balloon in the cervical area as opposed to the uterine area. So again, another suggestion to try and keep it in the cervical canal if possible. Randomized controlled trial with looking at pain with the saline fusion sonohystogram catheter. They used 69 SISs with a balloon, placed it intracervically, and 34 were in the uterus. They used the VAS pain system where you're looking at the face, and they found that it tended to be a higher pain level with people who were nulla gravida as opposed to the multiparous patient. And again, the cervical canal did better than the intrauterine for the initial placement. By the end of the procedure, it didn't make a whole lot of difference here. And the time was similar, and the volume was significantly less for those that had the balloon placed in the cervical canal. It's best to avoid touching the fundus, whichever method you're going to use. The fundus, when touched, is painful for patients, and they're more likely to have a vasovagal response. If you don't touch this, the fundus of the uterus, it tends to be the vasovagal response is pretty rare. So this is what we see on 2D ultrasound. As we're placing the fluid into the uterine cavity, you'll see that the endometrium separates and the fluid appears dark. On the transverse view, again, it's a 2D. We're going to see the uterus being distended. And when it's nice and smooth, this is a mid position. When we're seeing it closer to the cornua, you're going to see it look more like a lemon. And when we're doing a 3D capture, this one happens to be a rendered view where we have a box. So we've gotten our 3D view, and if we wanted to just have the multiplanar, then we wouldn't have this box here, and we just could rotate things based on where the green dot is. In this one, it's a rendered view, so we have a box here, and we can change that size of the box. I usually try and keep it a little bit smaller so I can look at the uterine cavity, and we can rotate this around, and we can see here the rendered view, so we're actually seeing the uterine cavity here. So with the SIS with 3D, we get this nice rendered view, and you can see this cavity very nicely. Again, you want to remember to slice through the uterus so that you're not missing any part. So there's a button that you just rotate, and you can slice and look up and down through the uterus. But it's very easy to see the uterine cavity this way. This is a 2D saline fusion sonohystogram that's showing a mass here. It's well circumscribed. It's about almost 2 centimeters by about 1 centimeter. And Doppler can be very helpful also for evaluating this. And if it has a single vessel coming into the mass, so this was having the saline a little bit more. You see a single vessel here. This is very common to see with a polyp. Sometimes you'll see a branch vessel coming out here, but this is also consistent with a polyp, nice round mass coming into the uterine cavity with a single vessel or a branching vessel. The prevalence of uterine abnormalities in infertile patients versus abnormal uterine bleeding patients showed that there's a pretty common finding of polyps, that 13% here to 30%. Fibroids are not uncommon. Submucous fibroids are the ones that we tend to worry about more with infertility and miscarriages, and we'll try and take care of those. And then, of course, you can pick up the uterine anomalies like arcuate's pretty common uterine finding. The accuracy of a polyp diagnosis when we're using a saline fusion sonohystogram versus transvaginal ultrasound or HSG, it's pretty, does an excellent job. Here it's listed all at 100 with this article by Suarez. Certainly has done better than the hysterosalpingogram, and it compares favorably with the gold standard, which is here is a hysteroscopy. Do we need to remove polyps for fertility basis? Well, there's very limited data on this. Most polyps are less than 2 centimeters and have probably little effect on IVF pregnancy rates, although most fertility specialists will remove polyps and not let them persist when they see them because it does increase miscarriage rate. There is a couple of studies that are older studies that have looked at pregnancy rates when randomized to either a polypectomy or a biopsy of the polyp and compared the pregnancy rates after using HMG and IUI. and those that had a removal of the polyp had a higher pregnancy rate of 63% versus biopsy alone. So limited data on removing polyps, but recommended by what we've seen here. Well, this slide obviously is a hysterectomy specimen with a big fibroid here. Now, for a fertility evaluation, we don't want to be doing a hysterectomy, but I'm just trying to emphasize here that these fibroids are not highly vascular. This is all white because there's not much blood vessels here. The blood vessels here are pushed to the side in fibroids. And a typical fibroid is going to be well circumscribed like this one. We'll see some shadowing coming down, and that's very typical for a fibroid. When we're doing a saline infusion sonohysterogram, we can see that this particular fibroid is in the uterine cavity, and we can see there's some shadowing below it. And then we can find fibroids in the subserosal area as well. So here we have the uterus, so the lining here, and this is the fibroid that's pushing out the serosal border. So happens to be a hypoechoic fibroid, a little less common. So when we're doing our baseline ultrasound, we should be able to see a number of these fibroids, and this one happens to be indenting the endometrium, so we'll be a little more worried about where this one is located, and we'd want to think about doing something more with that one. Some fibroids can be difficult to see. We can see a uterus here, you said suggestion of a mass, and when we use Doppler on it, we can see that there's a number of blood vessels that are on the outside of it, which is consistent more with a fibroid than, say, a polyp. Saline infusion sonohistograms can be very helpful with locating where the fibroids are. This happens to show that the fibroid's attached anteriorly and has, again, some shadowing here. So it's important to classify fibroids, and when you're doing a gynecologic ultrasound, I always like to identify where the fibroids are located, not only by submucosal, intramural, or subserosal, but I'm using the recommended FIGO typing more and more frequently now. The ones that we're most interested in from the fertility perspective are going to be the 0, 1, and 2, because the 0 is the one that is completely in the uterine cavity and will be one that we'll definitely want to remove. The type 1 is also impacting the cavity, having less than 50% in the myometrium, so more than 50% in the uterine cavity, again, one that we'll want to remove. And then the type 2 is the one that's going to be tougher. It has more than 50% in the myometrium, but it still can have an impact on the endometrium, and so we get very worried about that. There's not a lot of vascularity in these fibroids, so if an embryo tries to implant over the fibroid, we fear that there'd be less nutrients and a higher incidence of miscarriage. And we do see as we remove these that they have improved pregnancy rates with lower miscarriage rates. So this happens to be an older 3D volume. We have that transverse uterus. We see something's going on here. The longitudinal portion, again, a little bit unclear, but this coronal view during the luteal phase shows the endometrium nice and white, and we can see that there's a fibroid here in the, like a type 0 in the uterine cavity, and then we see another one that's impacting the cavity here in the coronal area. Yet does not bulge out the serosal border. And again, that would give us a type 0 and a type 2, and the saline infusion sonohysterogram can be helpful for that. But whenever we're worried about a type 2 fibroid, we want to make sure that we're looking at where that serosal border is. If we're thinking about removing this from a hysteroscopic viewpoint, we're worried about whether or not we're going to end up perforating the uterus. So typically when I'm doing these, I'll just shave them down, and I'm not digging into the myometrium at all. But I do measure that distance between the border of the fibroid and the serosal border to help guide the gynecologist who's using my report, or to help guide me in the operating room. And again, we can measure that very easily on this 3D coronal view. The coronal views can be very helpful, especially during the luteal phase, because the luteal phase is like an internal contrast material where the endometrium really lights up, and you can see by these arrows where there's a fibroid indenting the cavity. Again, the type 0, 1, or 2 can help us determine what type of surgical approach we're going to take. If it's type 0, we're going to counsel the patient that we're likely to remove the entire fibroid as long as it's not too big, usually less than 3 centimeters. At type 0, we can get out with one hysteroscopic procedure. At type 1, I'm typically doing these hysteroscopically only, and they tend to come into the cavity as I shave it down to the endometrium, and then I'll let the uterus contract and it'll come more into the cavity, and we can often get most of that fibroid out as well. The type 2s either have to have multiple hysteroscopic procedures or go for abdominal myomectomy. And so the ultrasound can be very helpful for planning our operative procedure. Intrauterine masses, again, do increase our miscarriage rates and decrease the pregnancy rate, so we do like to get these fibroids out of the uterus prior to fertility treatments. When you think about fibroids and their impact on fertility, there's been really no large-scale studies looking at patients that have multiple fibroids and large fibroids and their impact on fertility. Certainly there are many patients with infertility that have fibroids. We also have many patients with fibroids that conceive easily. So it tends to be a clinical opinion that fibroids play a role in infertility, and we usually will have that as a back burner diagnosis as opposed to a true cause. But it can be a cause in 2 to 3% of our patients. When we look at some of the old data from a number of papers and looked at pregnancy rates from IVF in patients that didn't have the fibroids removed, either we had fibroids that were not in the cavity, and you can look at the pregnancy rates there versus the controls, and only 2 of those papers had individuals with fibroids that were indenting or distorting the cavity, and these had a significantly lower pregnancy rate. When submucosal fibroids are identified either by these retrospective studies or a prospective study, when you look at the implantation rates, they're lower, the clinical pregnancy rates are lower, and the miscarriage rates are significantly higher. Removing them did improve the pregnancy rates as well. Intramural fibroids in ART, there have been about 10 studies. The combined data showed no impact on pregnancy rate. If you look at the confidence interval, it did cross 1. No impact on live birth rate. Miscarriage rate was also not impacted here because it crossed 1. The pregnancy rate after myomectomy, again, no difference because it crossed 1. And miscarriage rate after myomectomy, again, not an impact. So the intramural fibroids, although there could be other symptoms associated with it, for fertility purposes, we don't need to do much about those. Large fibroids and pregnancy outcome. We did a study on this. This is the Chevelle et al. Paper, where we took women who had large fibroids over 5 centimeters in size versus small fibroids. The bulk of the papers regarding fibroids, are looking at fibroids that are smaller, usually less than 3 centimeters, and oftentimes only a few of them, 1 or 2. And here we're able to show that it can have a significant impact on pregnancy outcomes. So earlier deliveries at 36 weeks versus 38 weeks with a p-value of 0.002, certainly an increased risk of premature rupture of membranes with 0.004 p-value, preterm delivery, and postpartum blood transfusions were all increased. Blood loss is also a little bit on the higher side. When you look at fibroids and pregnancy outcomes with short cervix, preterm labor, or PROM, when you're looking at 0, 1, 2, or 3, large fibroids, again, greater than 5 centimeters. When you're having 2 or 3, there's certainly a much higher incidence of these problems. Intrauterine adhesions can also be detected on ultrasound. The criteria for 2D ultrasound is usually, you'll see an asymmetry of the endometrial echo in the mid-cycle, although that can not always be the most reliable. When you see in the area being thin, less than 2 millimeters, it's suggestive, and it tends to be more echogenic. The accuracy is about 52%. However, if you do saline infusion zone histogram, you're going to see that it's stuck together and it's a much higher accuracy rate in the mid-90s. So consider zone histogram if you're looking for intrauterine adhesions. This is showing a filmy adhesion at the arrow. You see again the fluid in the uterine cavity, and the adhesion is that white line shown at the arrow. Now, uterine synechia may be detected on histosalpingogram like you're seeing on the left side where the arrowheads are. Again, you can see that on saline infusion zone histogram with a transvaginal ultrasound with this retroverted uterus, and these are some adhesions at this arrow here. When we're operating, these adhesions look like bands, and we can just cut them, and we'll usually treat them with higher dose estrogen and keep the uterine cavity separated, maybe with a balloon for a period of time. But it's very important to remove these in order for implantation to occur. So usually the treatment is a surgical approach, removing the scar tissue, again placing that balloon that will keep the edges of the endometrium apart while the endometrium is healing, and we'll usually use a higher dosed estrogen to help build that endometrium quickly, leaving the estrogen on board for 1 to 2 months, and then give them a withdrawal bleed. Certainly we can reevaluate the uterine cavity with another saline infusion zone histogram to see if it's really resolved. Now, what about tubes? When we're thinking about the uterine evaluation, we also want to be thinking about whether the tubes are patent or not, or are they normal or not. And with an ultrasound, normal tubes should not be seen. If we see something that looks like a hydrosalpinx, we might see that be a tubular structure or incomplete septa or cogwheel sign or small round projections, a waist sign, or sometimes you'll just see a compilation of 2 or 3 cysts kind of lined up that will give you a hint. If you just turn your probe, you'll see that it's actually a hydrosalpinx with just bent on itself. So here is a pretty clear looking hydrosalpinx that shows up pretty nicely here. When you look at Patel's paper, he nicely identified the tubular structure, the incomplete septum here, the cogwheel approach that shows that inflammation with the clumping there, and then the laparoscopic approach seeing the hydrosalpinx there. So in Dr. Patel also described what was called a waist sign. So if you see a tubular structure with this indentation here but no septum going across, this is highly characteristic of a hydrosalpinx as well. And he looked at the different types of findings that we often describe with hydrosalpinx and compared it to other abnormalities that we might find. He did a likelihood ratio and found that, you know, these findings are between 2 and 20-fold likelihood that you're going to see a hydrosalpinx if you see these ultrasound structures. So once we pick up a typical structure, it's pretty likely that it's a hydrosalpinx. Now, hydrosalpinges and fertility, a number of retrospective analyses and IVF cases have demonstrated that the hydrosalpinx impairs IVF outcome, reducing pregnancy rates by 50% and increasing miscarriage rates by 2-fold. So it's very important to find these hydrosalpinges and to appropriately counsel patients regarding these findings, plus the increased risk of an ectopic pregnancy if the tube is, you could still have a hydrosalpinx with a patency too. And these just do not function well, so the pregnancy could implant in the tube easily. So what do we do for treatments for hydrosalpinx? There have been a number of them that have described. Some have given prolonged antibiotics. This was not studied prospectively. Although it is cheap and simple, it has not had a randomized controlled trial to see if it's efficacious or not. Aspiration or oocyte retrieval. Well, some of these older papers showed that there were no improved pregnancy rates or implantation rates by just aspirating at the oocyte retrieval. I suspect several of these are aspirated oocyte retrieval when people mistake a tube for a follicle. Just would be one that didn't get an egg in it. The technique that's been most useful is the surgical either tubal ligation or salpingectomy. Randomized controlled trials of 300 cases was stopped early in Scandinavia at 185 because they had a significant improvement in delivery rates with these larger salpinges being removed or ligated. So let's move on to determining tubal patency. to saline infusion, can we determine tubal patency with this approach? Well, certainly if we did a baseline ultrasound, did not see any fluid in the pouch of Douglas, and then found fluid in the pouch of Douglas after the procedure, then we can say at least one of the tubes is patent. If we use color Doppler or power Doppler as we're injecting fluid, and as the fluid is moving, we can see the color Doppler is going to show up, and we can actually see where it goes. It takes a little bit of post-processing techniques to use that method, but I'll show you an image of that. And then contrast material. Well, we haven't had any approved contrast material for this particular technique, so an agitated saline technique was described in the early to mid 1990s, and I'll talk about that in a minute. Optison and Ecovis or other, and I think now Definity has been our contrast materials that have been off-label use until recently with Definity. And this is a way to see the tubes being patent. The agitated saline is basically using the same saline that we would be injecting to do saline infusions on a histogram, but now we're going to just put a cc or two of air in the syringe with our the rest of it being saline. So if you had a 10 cc syringe, that would be 8 of one and 2 of the other. Shake it and then just inject a few cc's of saline, not air. So once you shake it, the saline is going to have bubbles in it, and you'll see that easily on the ultrasound. And then you can look again at the cul-de-sac. If there's no fluid before and now there's fluid, it certainly is telling you that at least one of the tubes is open. And if only one tube is open and the other tube is blocked, the pregnancy rate only goes down by about 5%. So it certainly is sufficient if that's the only thing we find out. However, if we're doing the power Doppler, we can see where the color flow is and do post-processing. We can see that this tube coming out here is spilling dye or spilling fluid with power Doppler, and that's showing tubal patency. If you use the air contrast, you can certainly see the bubbles in the uterine cavity. Again, that kind of lemon look here where you can actually see the proximal portion of the tube. You can see the bubbles going out here. You may not be able to track the bubbles all the way out to the end of the fimbria, but you can usually see the ovaries and see fluid accumulating, and usually fluid accumulating with a few bubbles in it around the ovaries. So I usually look for both the proximal and the distal fluid before I would call it patent. And SIS, we have 79% agreement when we're determining whether the tubes are patent with an 85.7% sensitivity and 77.2% specificity. So it's a pretty good technique. There have been a couple of devices that have been developed recently that have helped people who may not be as great at looking at the corneal area. And basically what it is that it's just a device to help you inject the fluid. There's an air chamber and a saline chamber, and you'll just drop the fluid here, and then you'll be connecting this to your catheter, and you'll inject it, and it gives you a kind of uniform bubbles and makes it really easy. Similarly, AbbVie came up with another technique to do the same thing, and it's just a different way to do an agitated saline test, and this has been allowing people who want to do saline infusion zone histograms for patency determination a much higher likelihood of being successful looking at the proximal and distal tubes. And with this particular comparison between SIS and HSG, we can see that actually the SIS did better in sensitivity, specificity about the same, positive predictive value, negative predictive value. So it fared very well with the HSG. Ecovis has been available in Europe for a long time, and here you can see again the contrast going through the tubes, and you can see it over by the ovary here. That's not FDA approved for use in the US. Ultrasound. In the infertility evaluation over this hour, we've shown that ultrasound has truly revolutionized the infertility evaluation. The entire evaluation can be done in the office. The ovaries are evaluated both on baseline ultrasound where we're looking at ovarian volumes, and we're also looking at antral follicle counts during that baseline ultrasound to predict response. The antral follicle count tends to do exceptionally well with helping us determine which protocol to use. It's also a good place for us to rule out any ovarian pathology on that baseline ultrasound. The uterine pathology certainly can be detected with congenital uterine anomalies, polyps, fibroids, adhesions. Both the 3D and the saline infusion zone histogram will help us with identifying these pathologies. And then tubal patency and hydrosubpterygies are easily detected with the use of ultrasound and saline infusion zone histogram with an agitated approach. SIS has the ability to replace HSG, and it has replaced HSG in 18% of offices in the United States at this time. Ultrasound has become a mainstay in the infertility evaluation, and I certainly hope that you have found that this presentation has been helpful. If you have further questions regarding the infertility evaluation and the use of ultrasound, please do not hesitate to contact me. I left my email there for you. So thank you so much.